Good morning.
Good morning.
It is very nice to see you.
You too.
Welcome aboard. And good morning to all the ladies that will be coming up. I have our questions ready.
Well, I do want to know, learn if you were welcoming me aboard a yacht or a jet
Oh no,
plane.
it's that train.
A train. Okay, it's all
Yes,
aboard. Right.
all aboard. Choo choo. Anyway, one of my favorite things to do as a kid. That was fun. Hoping you're well.
Oh, yes, I am.
That's
Thanks.
good. Yay. Me too. So we do have our questions, and why don't we get started?
All righty.
Okay. So, question number one, Dr. R comes in saying, why do we put estrogen and progesterone at different application sites? Would you mind at some point maybe to do a very short video on where the best places is that we apply our hormones? Thank you.
Yes.
And
It's a
yes.
good question. You know, we've come up with our own approach to all of this, and there are many approaches. But here's the bottom line: the best and safest way to apply estrogens, to take estrogens, is through the skin. Absolutely, absolutely. There's a certain risk when you take estrogens orally, and we don't. It's a rare situation, but we don't want any risk, extra risk. So we always apply estrogens topically, and they work fabulous. They absorb beautifully. They're amazing. And I got 25 years of experience and testing behind that particular statement. The same is true of testosterone. We do not want to take testosterone orally.
Mm.
It's not safe for the liver. And so we apply testosterone topically to the skin, and it works beautifully. And it absorbs beautifully, and it always works. And we've got, again, tons of laboratory data backing that up. And then progesterone, we love to apply to the skin, especially in young women in their 30s as their progesterone starts to decline. It's so easy to get over the counter progesterone, even. I mean, my favorite always is our organic oils based compounded topical progesterone. And yet, a young woman in her 30s has easy access to all kinds of over the counter progesterone. And you apply it to your skin, and it works beautifully. Now, we also very commonly administer progesterone orally. We have special individualized doses compounded by compounding pharmacists of micronized progesterone. And that's my favorite. I'm not for the commercial one because of reasons. And the reason we turn to orally commonly is we can get much higher doses of progesterone in orally. And they have a special sleep benefit when they do what they do orally, which is get processed by the liver first. About 80% of what you swallow gets processed by the liver first. There's a special metabolite that really facilitates sleep. So sometimes we turn to oral progesterone. And my favorite way to administer DHEA is also topically. We actually combine it with testosterone. And that works really well. And oral DHEA is also safe, and many prescribers prescribe DHEA orally. So I'm giving the general overview there. But estrogens, by my favorite, and testosterone, absolutely through the skin. There are mucosal surfaces that work really well for estrogen and testosterone and anything else that you apply to the skin. The external perianal mucosa, the outside of the anus, after a shower, works really, really well. Mucosal surfaces tend to absorb even better than the skin does. And at the same time, I had been recommending this to women for years, and then I started applying my own testosterone. Here's my testosterone there, and I went, gee, how fun is this? I don't know. I think I'm going to apply my testosterone to the skin. And I just honor the hundreds of women that did apply to the external perianal mucosa. No one ever commented on it, but we've shifted in the menopause method where we recommend applying testosterone. And the vagina works really well. The labia, the absorption is great in the vagina, in the labia, but there's a challenge there. For those women who are having intercourse, you don't necessarily want to apply it to the vagina, and because it lingers in the vagina. And how do I know that? Because we had a woman in her late 30s who had gone into premature menopause. She had gotten severe vaginal atrophy. She was very sexually active with her husband, and she had pain on intercourse. And so we suggested that we do occasionally is that she actually apply some of the some additional estriol besides the bias she was applying to her skin. We suggested that she apply additional estriol intravaginally, and that really facilitates and accelerates the healing of the vagina, which always heals good enough. Even any woman who's got pain on intercourse, eventually that vagina heals. And so we had her apply intravaginal estriol. And then there came a time when her general body levels of hormones had replenished to the point where she was no longer symptomatic. And we wanted to do the 24-hour urine hormone test, which we always do. And here's what we learned. Well, she asked us, do you think I should omit that vaginal estriol prior to doing the urine collection? Well aware that the urethra, the emptying of the bladder tube, goes into the vagina, and she might pick up some direct estriol that she had applied to her vagina. She understood that. And we said, yes, please do omit. And the recommendation from the laboratory was that she omit for 48 hours any intravaginal estriol. And being the scientist that she is, she omitted for 60. And on the 24-hour urine hormone test, her estriol levels were astronomically high. That estriol had lingered in her healthy vagina. Which means that if you're having active intercourse, your husband's going to get exposed, most likely, to estrogen, and we don't want that. I mean, yes, we men do need a certain amount of estrogen. That's a whole other story, but not much, and not so. That would be one reason not to do it. The other reason is if a woman is applying these hormones intravaginally, it's going to interfere with the 24-hour urine hormone test, and that's highly consequential from my perspective. I've had a recent talk with a laboratory owner and director of a lab that is trying to sort that out and how they're doing things. And this is a brand new thing, so I'm not going to go deeper into it, but I'll keep you all apprised of what we're learning, because we're proposing doing a study of laboratory testing of women in menopause and men in andropause by doing multiple split specimens. So that's another story for another day. Bottom line, estrogen and testosterone absorb beautifully from the skin. So I've never had an issue where we couldn't get the estrogens by a biased, and I know some people are using estradiol, I recommend biased, and testosterone through the skin. So there's no reason to apply it, as far as I can see, intravaginally. Now, to jumpstart the healing of a vagina that is not healthy and is atrophied, yes, we will often recommend that women apply the bias directly to the vagina, one of the drops of the several drops that they're applying to their skin. Now, we do have videos, and I'm going to post access to those videos. Excuse me for turning my head away, but I'm going to, if you just bear with me, I meant to have this, and I'm so sorry that I didn't. Have a link to the videos that I'll post in the chat, and you can post these videos on ins and outs of menopause, and I'll get this together here.
Thank you. Is it the woman, the really pretty woman with the brown hair?
Yes, Donna.
Yeah, it's a good
So
video.
this is the videos that we've prepared for everyone who's using the oils, but they apply also to women who are applying anything to their skin. So no
Thank
problem.
you.
And what else? We
Um,
recommend what we recommend applying bias twice daily. There's reasons for that. I describe those reasons in our book. We recommend sometimes different sites. Like we always begin with women applying the bias to their forearms, the soft part of their forearms,
yeah.
and the progesterone to the lower abdomen, inner thigh, posterior deltoid region. There's all kinds of places for the progesterone. Testosterone will often recommend the inner thigh if they're not applying. And sorry, my favorite place now for testosterone is the groin, right above the groin, in the soft lower abdomen, the right side and the left side. And testosterone is absorbing beautifully from there. It's sort of a metaphor. It's sort of you're applying testosterone if you're lying down on your back over your ovaries. I'm looking aside here so I can get the link. That's what I'm doing right now. So, and I'm going to post that link in the chat. I think I can do that.
Well, that'd be interesting.
These are the link to 2 videos. So, Carolyn, maybe you'll tell me if this actually shows up.
Yeah, I will.
And you can post that on the ins and outs of menopause. So that's where we like testosterone. It's sort of a metaphor. You're applying it over your abdomen. It's sort of, if you're lying on your back, over your ovaries. Not that that's how it works. It's not going right into your ovaries, but I don't know. That lower abdominal area for the testosterone. Why do we like different sites? It's not imperative that you do different sites. There's folks who are combining, for example, bias and testosterone, or all 3 hormones or all 4 hormones. I'm not a fan of that. I am a fan of combining the testosterone and the DHEA, still to find out ultimately by testing what the optimal concentration of that testosterone is in the combination with DHEA, and what that optimal dosage of the DHEA is in combination with testosterone. There are folks who are combining. I'm not a fan of it. For example, you mostly want to take your progesterone at night because progesterone helps you sleep. Now, there are some women who take their progesterone during the day. It's not common, but progesterone can alleviate some anxiety for women who have anxiety in the day when they didn't used to have anxiety, but when they went in the perimenopause and the menopause, they have anxiety. Progesterone can be wonderful for that because progesterone is the great calmer. Testosterone, we really want the women to take it in the morning, just like I take my testosterone in the morning. Testosterone's activating. You don't want to necessarily be activated when you're going to sleep, so you wouldn't want to combine testosterone with your progesterone. What it all comes down to is the only thing we combine is testosterone and DHEA. Bias can be activating as well, so sometimes that needs to be taken at a different time. If this sounds like a lot of information, we go into great detail on this in the book. And yeah, I'm not a real fan of combining. These are different sized molecules. Their rate of absorption is going to be different. Yet, if someday we'll do the study where we'll do the combining, we're already doing this testing the testosterone and DHEA combination. It works great. So we know that works, and we don't recommend that you combine the bias with anything because you're doing it morning and night. That's the optimal way to administer bias. And we're doing the progesterone primarily at night. So we keep those in separate bottles. So in the menopause method, we dispense 3 different bottles. One of them is biased, one of them is progesterone, and one of them is a combination of testosterone and DHEA. And we apply these to different sites. It's not like other things don't work, so I don't want to say anything absolute around this. So
Right.
you asked the question, so there's the long answer. When you really get the ritual down, I know it sounds complex, but what it's going to amount to, you're going to apply your hormones twice a day. And we even have an app now that you set the alarm for your weekdays on to apply the hormones. You set the time that you want to apply, and you get a little ding on your phone when it's time to apply the hormones. So I don't want to make it sound overly complex. Once you get this down, it's just so automatic. Women apply their hormones twice a day for the rest of your life, just like I apply my hormones daily for the rest of my life to my skin. Bravo. Fantastic.
Very big bravo, very big fantastic, and I do the same exact thing, and I'm very excited about it because it's made me a lot better, and I thank you for that very much. Well, thank you for that answer, and thank you also. I do have the site up here, and I will keep it up here, and I will also post it on the ins and outs. Our question number 2 comes in saying, when starting bioidentical hormone therapy, is it okay to start low with a low dose of estrogen and then after about a month or so bring in the progesterone? I know that there are many sites, meaning groups, about that say that estrogen taken alone is dangerous. Do people take estrogen and progesterone together ever from the start?
When I started out, I had a theory. And the theory was I thought it would be good if a woman could start with just one hormone so she could get an internal feel of what that feels like. And for a short period of time, that's what I did 25 years ago. And then I rethought it. I wasn't getting the kind of symptom relief that women would like to have. I knew that a woman's body didn't do that. A woman's body didn't just deliver one hormone at a time. And I didn't think a woman was going to be getting the clear picture. So very early on, I started suggesting that women start low doses of estrogen, relatively low, and low doses of bias and low doses of progesterone. So I did have them applying both of them right out of the gate, bias and progesterone. And then after a while, that was successful. And it's not hard to tell the difference between progesterone and estrogen and what it feels like in your body. And the symptom alleviation was so much better than starting with both biased and progesterone. These days, we start with all three in 95% of the women. There's some women that they have this unique biologic increase in testosterone in the perimenopause and menopause, early menopause, because the body can compensate for low estrogen by increasing the testosterone output both from the ovaries and the adrenals and convert that testosterone to estrogen. We think that's why that happens. These are not common. I'm mentioning exception here. We start 95% of the women on hormones. When we start them with all three: bias, testosterone, DHEA, all four: bias, testosterone, DHEA, and progesterone. We don't initially titrate the doses. We give women a steady dose of the testosterone DHEA mix, titrate up. That means we start low and gradually increase the estrogen, the bias, and the progesterone. And then once the bias and progesterone have settled in and alleviated symptoms, then we might increase the testosterone, especially based on test results. But I know I'm like a fire hose of information. I'm a little concerned that I say too much too fast. And so I'm going to slow down a bit. So there's many ways to do this, and that's how we do it these days. I'm going back to that exception. There are some women that actually increase their testosterone output and I believe it's to compensate for the low estrogen, because you can convert testosterone to estradiol.
Interesting.
Yeah. But I used to see a lot more of that increase in testosterone blip 25 years ago than I see now. Testosterone's just like estrogens are recruited for the biology of the fight or flight response. And by the time most of the women that we're encountering enter the perimenopause and menopause, they've over-recruited their testosterone. It ain't going to blip up. It's depleted. I can tell you by 3 years, I've never run into a case of testing women with 24-hour urine hormone tests that the testosterone and DHEA weren't low. Always, 100%. So we know that the odds are so high that the woman's already depleted in testosterone and she needs it, that we start it right out of the gate there. We start all 4 ovarian hormones right out of the gate in most women. Now, we take such an extensive medical history on our app these days that we can tell when a woman's getting a testosterone blip, just like we could in the old days. A woman goes into the perimenopause or menopause and she's getting some hair on her mustache area and on her chin. She's getting oily skin and she's getting some pimples. Woo! These women are getting the blip. And they're getting a boost of testosterone in the perimenopause. And so we're not going to give these women additional testosterone. That's so obvious. We're going to wait, though, because they're going to run low. And when you give the women estrogen and progesterone, that's often the remedy for that testosterone blip. They don't need it to increase, so the acne disappears and the hair on the chin no longer is growing. Does it sound complex, folks? Yes.
It doesn't sound like Menopause 101, I'll tell you that. But
it always takes me back to the exact same thing. Is we love women to have a certain amount of knowledge about this because these hormones are going into your body and you can get expert at it in a certain way that's terrific. However, I assert that the one job that you have when you're starting to get symptomatic in the perimenopause, or you're in early menopause, or no matter how old you are, if you're 80 or 90, you seek out a healthcare professional that, number one, can write your prescription, because you ain't getting these hormones unless someone can write you a prescription.
So true.
But really, someone who really cares about this and has really gotten an education about how to do this. And ideally, someone who's got some experience and really loves this work. And the best case scenario is if they're specializing in it. So this is your job. If what I'm saying sounds too technically complex, you know what, it isn't. If you watched every video we've ever posted on menopause and you read our book, you know what, you start getting the hang of it. Even the professionals that we have a 12-hour training program for, and grand rounds and a mentoring program even for some select few of those who really want to master it, it takes them time too, and they've got this fabulous medical background that is terrific. They're used to learning this stuff and they understand the basics. So if you want to learn, just watch all our videos and read our book. You'll get it. It'll take you a while, but you'll get it. Anyway, I want to take you back to your main job. If this sounds complex to you, there's a part of it that is simple for you, that you really need to know, and you'll learn that, and you can learn that from our book. You can download a free PDF version of that book from Ins and Outs of Menopause. But your main job is to find a healthcare professional who can write those scripts for you and really knows what they're doing, because some of the time it's pretty simple, pretty straightforward. A woman is in perimenopause or menopause, you give her hormones, she feels better, end of story. But I'd say 90% of the women that I ever encounter, they require individualization. It's a process. It takes us between 4 and many more hours for some women to figure it out the first year. Once you dial it in the first year, you're good to go, usually for many years. We follow you annually, but it just takes an hour or two each year. You don't take much. But that first year of really individualizing it for your body, because every woman differs according to how much they need, what the balance is between the 4 ovarian hormones. Do they need thyroid hormone in the mix? How sensitive they are to anything you give them, how well they absorb things. There's a lot of variables there. It's not a problem for at all. It's fun. It's entertaining. It's like a big Sudoku game, if you know what that is. It's like a Rubik's cube.
Right.
Fun to do that, and it never is boring to do that. for someone who cares about this, has an education in it, and is seeing patients regularly. It's no problem. So I don't want to pose this as a problem at all. It's not. It's fun.
It is fun.
Fun for me to solve these things.
Absolutely.
But so don't be overwhelmed. Do what you really need to do, which is go shopping and find a healthcare professional, a physician, a nurse practitioner, a PA, or a prescribing compounding pharmacist who really knows this stuff, really loves it. Then you'll have and you like. That's another thing that you like and trust. You find that person, you're going to go on a journey. It's going to be an enjoyable journey. And the best thing is, number one, you're going to feel better and you get yourself back. And number two, you're going to get deep protections that you're going to treasure your whole life. Your bones, your muscles, your vagina, your bladder, your mind, your arteries. Whew, just to name a few things that really matter. So get the out shopping for that provider. You'll find them. And if you have to switch providers, it's like anything else. Sometimes we got to switch. So,
You say thank you
well,
very
and
much.
Antoinette, please contact Sherry. I'm going to give you her email. She may be able to help you as far as getting the oils.
Sherry's amazing.
So I'm typing this into the chat. Sherry is amazing.
Oh, is she ever? Boy, I heard her voice that first time and I was flabbergasted. So happy. Thank you, Dr. R, very much for the answer to
Did we
that.
answer Teresa's question? Why don't you ask?
Sure. Hi, Teresa. Good morning. Teresa is saying they gave me a 200 milligram pill, and it seems so high a dose to me to start with. Still afraid to start. Does that sound like a high dose to start?
One thing about progesterone is you really don't have to be afraid. It's, but I know that's a common practice, and it's not a practice we do because women vary woman to woman as how much progesterone they need, and whether topical or oral is the optimal way to go. Just to give you an example, in the menopause method, we give out when we're switching to oral progesterone, because that's what Teresa's talking about. A 200 milligram pill is oral progesterone. It's a pharmaceutically manufactured dose, most likely. I'm not a fan of it because it's in peanut oil and it has some funky stuff in there. It's got some dyes in it. So I'm not a big fan of it by any means. But if it was the only tool I had, I would use it. That's for sure. And we start every woman with 2 different bottles of oral progesterone, compounded, micronized capsules. One of those bottles contains progesterone 25 milligrams, and we give out 30 of those. And the second bottle contains progesterone 50 milligrams, and we give out 30 of those. And we start most women, but not all, on 50 milligrams a night for about 3 nights. And every 3 nights, we increase it by 25 milligrams. So it's 50 milligrams the first night, 75 milligrams the second 3 nights, 100 milligrams the third 3 nights, et cetera, et cetera, et cetera. We love to maximize that progesterone, so we'll keep climbing. When a woman takes an excessive amount of progesterone at night, she's going to get one of the calming effects of progesterone so deeply that when she wakes up in the morning, she's going to feel groggy, like she took an overdose of a sleeping pill. We know that's too much. So worst case scenario, if you took that 200 milligram pill and you woke up feeling groggy, it'd be too much. But it wouldn't hurt you. You just feel groggy. It'd mess up your morning, usually, maybe even longer. So we have a woman gradually increase that oral progesterone until she wakes up in the morning groggy. Then we have her back down by 25 milligrams. That's her dose. And we put all of that dose into one capsule because it's easy to do. In my practice, women come in somewhere most commonly between 50 milligrams and 150 milligrams. There's some women that can't even take 50 milligrams. They get overdosed with less. So there's some women we start on 25 milligrams. There's even women who take less. But most common in my practice, women will land somewhere at 50 or 75 or 100 or 125 or 150. There are women who really thrive on more. 175, 200, 225, we'll push it. And since progesterone can really help the cells that lay down new bone, it's the only substance I know, progesterone, that stimulates the cells that lay down new bone to lay down new bone, osteoblasts. So women who have any form of osteopenia, osteoporosis, we try and maximize that progesterone, get it as high as they can tolerate, then back down a little bit.
So I guess that
that's how we handle oral progesterone, and it certainly is different. There's never been a case where I started a woman off with 200 milligrams because I know that's just too much for some women. So we do the ritual that we do.
Titrating up. Thank you. My third question comes in stating, I have finally found an integrative physician and I've been able to get my compounded bioidentical hormones. I'm very excited, but I'm really struggling with anxiety right now. And my doctor has prescribed a medication for me to take along with my hormones that is not a hormone. And I hate to start two meds at the same time, but I'm wondering if anybody else has this anxiety and if they take these other medications along with their hormones. And I was wondering your thoughts on that, Dr. Rosensweet.
Carolyn, is that anti-anxiety a pharmaceutical medication designed for anxiety? Like they're usually pretty strong. Is that one of those strong ones?
Well, it would be more along the antidepressant line.
Okay. It's not my favorite way to go, but this doctor knows a lot more about this patient, a lot of details, and there are times when medications are called for. Anxiety can be so disabling that sometimes a run of an anxiety medication, which are very strong and can do the job, is worth it. And so I never say never. Now, this is not my first approach. I just don't know enough about this particular woman. And that's the kind of thing we find out prior to that first visit when the woman fills out a very, very, very extensive questionnaire, and we get a lot of details there. But let me give you an example. There's a lot of women, I mean, we all get nervous or scared or, have emotions, but that's not what we're talking about. When I hear the word anxiety, I think it's that more intense kind. And there's some women they didn't really have something called anxiety when they were in their 20s and 30s. They might have had their ups and downs, like we all do, but they didn't have something called anxiety. And then they go into the perimenopause and they get anxious. Oh my God. There's such a common reason for this. So it's the loss of the hormone progesterone. Most hormones that you can think of, these are the most powerful biochemicals in our body. A lot of them are recruited for the biology of fight or flight. They're so energizing and activating to metabolism and mood and everything you need. Estrogens, testosterone, adrenaline, cortisol. Man, these hormones are royally a part of fleeing from a saber-toothed tiger or whatever other stress is in your life. Not progesterone. Progesterone's a very unusual hormone in that regard. It's the great calmer. Sometimes women who are pregnant, commonly women who are pregnant, they have these Buddha-like states where they're so calm and so at peace, and it's because of the astronomically high levels of progesterone that are floating around in their body. Progesterone is so calming that if I chose the right dose for you, Carolyn, or for me, David, and I injected it intravenously of progesterone, we could be put to sleep so deep surgery could be performed on us.
Crazy.
That's how calming progesterone is. And like I said earlier, when a woman takes an overdose of progesterone at night, she wakes up feeling groggy, like she'd been on an intense sleeping pill overdose, and she's still experiencing the afterglow of it. Progesterone is the great calmer. So there's so many women who go into the perimenopause and it can creep up on you. Or you're living your normal life, you're starting to get a little more upset than you used to be, and you're starting to have some mood issues, and you're starting to get some anxiety, and then sometimes it gets so severe that you feel like you're going crazy. That's how severe it can get. So I'm going to tell you the story of why you and I, Carolyn, you know this so well, but why you and I are on this Facebook Live today. This is how it happened. 28 years ago now, I'm sitting in my office in Santa Fe, New Mexico, early in the morning, trying to get some administrative work done before I start seeing my patients. And one of my patients slams open my office door, walks up to my desk where I'm sitting, and pounds her fist on my desk. Bless her heart, Deborah. I knew Deborah very well. She was angry, and she was angry at me, and she said to me, "Don't think you know who I am. Because right now I'm going crazy, and I don't want to hear something from you like you don't think it's a big deal because you think I'm fine. I'm not fine. I'm going crazy. Please help." She was afraid I wouldn't really get the seriousness of the moment because I knew she was a brilliant and strong woman, so high functioning that she had retired in her 40s. Come on, give me a break.
She meant it.
I was not in a position to retire in my 40s. What does it take to pull that off?
Yeah.
And serendipitously, although my own journey through medicine has been divinely guided always, I know that it's really just so remarkable and so sacred, and I'm so grateful for it. I'd been speaking to a medical doctor who was popularizing this in the early 90s, the hormone progesterone, Dr. John Lee. Bless his heart. He's no longer with us. He
His
did
books are, though.
Yes, he did such a service to us all by alerting us to the importance of progesterone. So I gave Deborah some progesterone, and 3 weeks later, I got a letter from her because that's how things were going in those days, saying, "Oh my God, this is amazing! I'm totally myself again. Thank you so much." And that was so impressive to me that someone had such a dramatic and beneficial response. It really opened my eyes, but I didn't control my practice. Deborah spread the word. In a very short period of time, I was seeing a lot of it, and then decided to specialize in it.
That was divinely
So,
inspired, too.
so to our questioner, the very first thing I would do is exactly what I expressed to Teresa. I would give you a bottle of 25 milligrams of progesterone orally and a bottle of 50 milligrams of progesterone. I'd give you some topical progesterone too. And man, every 3 days we'd have you jack that up and see what kind of effect that it had on the anxiety. And we'd have you do some topical progesterone during the day. That would be my first approach. No doubt about it. Think of Deborah. That's how I would.
You wouldn't be adverse to some sort of an intervention, but I think I've known you long enough that you feel pretty safe, oftentimes anyway, that hormones, when we get them right and balanced, that it's been my experience. I had a lot of anxiety. That anxiety did go away when I was able to balance out all of my hormones.
Yes, Carolyn, exactly. I would start with the hormones. These hormones are such powerful biochemicals. They're neuroactive, every single one of them. And that's where I'd start. But, this physician was sitting there in the office with this patient. And so they might know more than we know. So there's always the caveat. You never want to say never. This might have been a case where it was important to prescribe a tranquilizer.
Yeah.
So I never say never. There's something about an experienced physician sitting in front of an actual patient, and they make the call, and sometimes that call is an important call, and sometimes it's needed to tide the woman over till other things can be accomplished. So I don't know enough to say, oh no, they might have chosen the perfect things.
Yeah, yeah, yeah. Especially when you feel like you can't get out your front door, you know? I mean, it's a
Yeah.
really scary feeling, that anxiety. It's a different kind of anxiety than,
Then
I don't know.
then the fun type of anxiety. It's a different type of anxiety.
Yeah, not the fun kind.
Oh, maybe there isn't such a thing as the fun kind of anxiety.
Well, maybe that anxiety about getting on a roller coaster might be fun. I don't know. That would be about the only thing I could think of. All
Yeah,
the rest of them, forget it.
yeah.
Brooke is saying, if using transdermal progesterone, how many milligrams do you start on? Well, we did go over this. It would be like maybe 25 milligrams and then the 50.
Transdermal, no.
Oh, I'm sorry.
What I
Yeah,
was describing was oral,
my
and
apologies.
yeah, you can get over the counter progesterone. It's 1.8%. That's 18 milligrams per milliliter. That's safe for everybody. Ours starts out at 8.7 milligrams per drop. So, and we don't hesitate to go to 50 milligrams topically, bam, as fast as we can get there. And we can go higher than that. So progesterone is so safe, it's unlikely you're going to have any issues with it. So
Oh,
whatever you can get your hands on prior to linking up with this healthcare provider that you're going to go out and find, because that's your job.
nice. Thank you. Okay, moving to a little bit of a different subject here. Can hormones affect blood pressure levels? Lately, many women have been complaining that when they have started hormones, their BP blood pressure shot up. Mine sure did, and I'm not sure why. Do you have any thoughts on this, Dr. Rosensweet? And have you seen this happen? Thank you. I'd love to know what you have to say about this.
Fascinating. 25 years of specializing in treating women in menopause with compounded bioidentical hormones. I've never seen the blood pressure shoot up because of the hormones.
Interesting.
Now, you never say never in medicine. And I'm not challenging the questioner. I cannot possibly imagine a way that a woman, by taking estrogen, progesterone, testosterone, or DHEA, could affect her blood pressure unless there was a significant overdose.
Mm.
Estrogen's animating, testosterone's animating, DHEA can convert to estrogen and testosterone. It can be animating. But man, it's hard to get the doses so high that imagine that they could be that agitating. You can get agitation. You get agitation with excessive doses of estrogen and testosterone. That's going to be stressful. You can trigger the stress response, at the vanguard of which is adrenaline. That'll raise anyone's blood pressure so fast you can't even blink faster. And that's going to raise your blood pressure. I would look for overdose, or really, when a woman's getting high blood pressure, I would really want to hunker down and try and understand the nature of that high blood pressure. High blood pressure is to be respected, and because it injures us, but we don't necessarily feel it.
Mm.
It's rather remarkable of how high that blood pressure can get without someone feeling it. When it gets super high, you do feel it. But when I now, midlife is a common time that people are getting high blood pressure. They're discovering, oh, lo and behold, my blood pressure is higher than I knew. and they find it incidentally or they find it for reasons of symptoms. And in dealing with hormonal imbalance, you can get heart palpitations, racing heart from the stress response that's resulting from low hormone levels. Like there's so many women, I've heard this story from so many women, including my own sister, who woke up in the middle of the night, their heart is pounding in their chest. They've even got chest pain. They get scared that they're having a heart attack. I'm sure if you took your blood, I would suspect if you took their blood pressure at that moment, it would be elevated. And they go to an emergency room. That's how concerning it is. And what happened is these hot flashes that happen, and they happen because of low estrogen. The brain, the body, the hypothalamus is registering that the estrogen is too low. It tries to stimulate the ovary to produce some estrogen, and that's stressful to a woman. And when it happens in the middle of the night, she can get a hot flash, a night sweat, or not even get that, but wake up with racing mind and heart palpitations. And I would highly suspect if you took her blood pressure in that moment, you'd have high blood pressure, because there's no chemical better in raising the blood pressure than adrenaline. Physicians know this. In an emergency room, you get someone with low blood pressure, providing they're not hemorrhaging, and you want to raise that blood pressure because they're in shock, you give them some form of adrenaline, because there's nothing better to raise the blood pressure. And that adrenaline can be at the vanguard of the stress response that's occurring in the middle of the night. So as you start to see, there's several moving parts there. But what I would, just starting with the blood pressure, we do what we always do. We take an extensive medical history. At times, an extensive physical exam is needed, and we get the clues about what the heck's going on there. We do some laboratory testing, and we unravel the situation, why that blood pressure went up. And it could be hormonally related in ways that I mentioned, the hot flash in the middle of the night, sending women to emergency rooms with chest pain, thinking they're having a heart attack. You can bet that the core of that one is adrenaline. They've got triggered by the stress of the hot flash. So this is liable to feel like a blurry response. But I want to take you back to the basics. If you're in the perimenopause and menopause, you want to seek out the care of a health professional who really understands the whole story about it and how to diagnose it and treat it properly. And if you're throwing in episodes of high blood pressure, you want to seek out a health professional who's really good at blood pressure. They may be one and the same. And can it relate to the vicissitudes, the ups and downs of the ovarian hormones, or overdose of the hormones you're being treated with? Yes, it can. But all this is how we sometimes do some testing.
Hello, everybody. I lost Dr. R somehow. I'm hoping he's going to come back, which I believe he will. We have 10 more minutes to go. V, thank you very much for what you're saying. Sarah, I see what you're saying. Levon, I'm thrilled to hear what you just wrote. Dr. R, where'd you go? Come back. I'm going to see if I can find him, you guys. Give it a minute here, because you don't want to sit here and just stare at me. Let's see if I can find him. Give me a second, all right?
We're back. We're back.
Kinda.
Uh-oh, you got two. You got two computers on. We're back?
We are. Trip around the world. We are back.
I think we should make it says, oops, got an echo. You'll have to mute. You should make a tape loop that says, go shopping, find a physician, nurse practitioner, or advising compounding pharmacist that is expert at treating women in menopause with hormones. Go shopping, find that person. You need them. And just press a button every time. And that'll be the answer to every question.
True, but the thing is God, we could get into a whole thing around that. Yeah. But I agree with you because that is the thing for sure. We have a few minutes left, Dr. Rosensweet. This question is our last question, and we have some really lovely, and I will have those, so I can use them, the comments, but they were really, really nice. And the last question that comes in says, what ratio of oils work? And where does one apply these oils? Twice a day or one time a day? Now, I believe this woman is talking about bias, but I don't know that she's getting it, combined.
Yeah. What ratio? When the word ratio is used, when you're talking about compounding bioidentical hormones, it always applies to biased. Biased is a form of estrogens because a woman's ovary actually produces 3 estrogens. Estradiol is the most potent. Estrogen's about 80% as potent as estradiol. And estradiol is about 1/8 as potent, but it's more prevalent. It's the most prevalent of the 3 estrogens. There should be somewhere around 1.2 plus or minus times as much estradiol as there is the sum of estrone and estradiol. And they function differently. For example, once a month, a woman prepares for implantation and possible pregnancy. She prepares her uterus for that. She prepares her breast for possible breastfeeding every single cycle. That's how early that process begins. And to prepare the breast, there's a time early in that cycle when she's getting actual cell division and an increased number of cells of breast glandular cells. Process is called mitosis, cell division. She forms more breast glandular cells every single cycle, and her breasts get fuller. And that is under the guidance, so to speak, of a certain estrogen receptor site called estrogen receptor site alpha. Estrogen interacts with the receptor sites. That's how hormones work. There's the hormone, there's the receptor sites. The hormones go in the receptor sites. It's that interaction that triggers the effects of the hormones. Estrogen receptor site alpha is the proliferation. Woman's breasts get fuller every month. Actual additional cells is part of that. If she does not get pregnant, those cells disappear by a process so entertainingly called apoptosis. Those cells disappear once a month. That deproliferation, that apoptosis, is stimulated by a different receptor site, interacting with estrogens, estrogen receptor site beta. The most common inspirer of estrogen receptor site alpha is estradiol. The most common estrogen that is the inspirer of estrogen receptor site beta is estriol. So we think deproliferation is so important that long ago, Dr. Jonathan Wright proposed that we use Triest, but we learned we didn't need the estrone part, so he switched to Biest. He believed that every prescription for estrogen should be Biest, a combination of estriol and estradiol. And in order to produce in testing, hormone testing, a ratio of estriol to estradiol that copies nature, in other words, there's 1.2 plus or minus the amount of estriol as there is the sum of estrone and estradiol. In order to produce that, in order to copy nature, Dr. Wright proposed initially that we do a biased prescription that include 80% estriol and 20% estradiol. That's the ratio, 80-20. That's the ratio that this questioner is talking about. There's 4 times as much estriol as there is estradiol. And we start off every single woman in the menopause method with the same prescription, Biest, 30 milligrams per milliliter, 80-20. That gives us the proper amount. That gives us 0.44 milligrams equivalent to estradiol potency per drop. So when you get creams and gels, it's not going to be 30 milligrams per milliliter because you're not dealing with drops. You're dealing with a quarter milliliter or something like that. But Biest, that ratio is estriol to estradiol, 80-20. However, when we go to test women through 24-hour urine hormone tests, after they've been using Biest and they've settled in and their symptoms are alleviated and they feel like themselves again, they're not having hot flashes, glory, hallelujah, we do 24-hour urine hormone tests on these women. And we see, what does the ratio look like in the urine? Is it copy nature? Is it about 1.2, 1.3, 1.1? The amount of estriol compared to the amount of the sum of estrone and estradiol in the urine? Is it like that? If it's not like that, we will adjust the ratio of estriol to estradiol. Sometimes we see situations where it looks like there's just too much estriol and that 80-20 was too rich a prescription in estriol. So we'll change that ratio to 70-30, 60-40, 50-50. Our recommendation is no one messes with that ratio until they see a 24-hour urine hormone test, and they can do so with great precision and accuracy. And again, we're in communication with another form of urine testing. We're in communication with that laboratory. We're going to do a study, hopefully. I know I've been monitoring 24-hour urine hormone test is the only way to go, but I'm opening up to see are there other methods, and we're designing a study to see how they all compare. But you don't get to find out what the proper ratio is unless you're looking at a proper hormone test that measures estriol, estrone, and estradiol. You don't get to see if the dosages that you're administering, the ratio of Biest that you're administering, copies nature unless you test a woman that you're treating. And we find that 80-90% of the time when we start with Biest, 30 milligrams per milliliter, 80-20, that's the ratio, 80-20, 80% estriol, 20% estradiol, that we come up with the proper copy nature result when we test the woman. Sometimes we don't. Sometimes we see that woman needs some more estradiol and less estriol. And we'll change that ratio to 70-30. I realize I'm repeating myself. 60-40, 50-50. The wildest I've ever had, this is a real outlier, there's a woman that we're treating that her ratio is 30-70. 30% estrol, 70%. She's a landscaper, and she gets exposed to a lot of chemicals, and we think that her liver has been affected, so she's processing it different. But most common is 80-20, works for most women. 70-30 is needed, 60-40 or 50-50 are the most common things they're needed. And we have one doctor who's very excellent at this. She's a real devotee to hormone testing. She biohacks herself. She uses 45, 55, 45% estrol, 55% estradiol. So these ratios, we have calculators to assist physicians and providers on how to calculate the ratio once you're looking at a hormone test. So all kinds of things are possible in there. That's the ratio that's being referred to. And oh my.
Can't believe it. You went 2 minutes over. Love it. Dr. R, thank you so much.
My pleasure, Carolyn. As
We
always, fun.
Aw, thank you. It's good to see you. Thank you, ladies, all of you, for coming up. And we're going to see you again on Thursday.
Until then.
Until then, have a wonderful couple of days, yourself and to everybody else. And we'll see you on Thursday.
Thank you, Sal, for that beautiful comment to Carolyn.
We got some really nice ones today, for sure. Thank you, Sal.